Hi, thank you for being here today. I'm Nur Khairunisa binti Khalid from Plant Biotechnology student. I'm here today to talk to you about genomic study. From the research article, I choose one topic that is important to know. The topic is whole genome sequencing of Mycobacterium tuberculosis isolates and clinical outcomes of patients treated for multi-drug resistant tuberculosis in Tanzania. And then, this is Mycobacterium tuberculosis. For the introduction, whole genome sequencing (WGS) is a current alternative to the WHO-approved probe-based method for TB diagnosis and detection of drug-resistant, genetic diversity, and transmission dynamics of Mycobacterium tuberculosis complex, which is MTBC. Tuberculosis TB caused by Mycobacterium tuberculosis complex (MTBC) is the leading cause of mortality, killing about 2 million people each year globally. Tanzania is among African countries south of Sahara with the highest burden of TB, with an estimated 295 TB cases per 100,000 adults. The highest TB mortality and morbidity occurs in low and middle income countries like Tanzania. HIV infection is the most important single predictor of TB incidence across the African continent. This is critical because HIV and AIDS is likely to increase in the risk of progression TB infection by 30 times due to impairments on the immune system. For the methodology, there are 4 methods in this research, which are: first, sample collection, culture of MTBC, and phenotypic drug susceptibility testing. Second, DNA extraction and whole genome sequencing. Third, bioinformatics and genomic data analysis. And fourth, analysis of clinical data. For the first method, sample collection, culture of MTBC, and phenotypic drug susceptibility testing, 200 microliters of sputum sediments were inoculated on two slopes of algae medium containing ethyl pyruvate or glycerol. Culture and identification of MTBC colony were performed according to locally existing and CLSI standard operating procedure. Phenotypic drug susceptibility testing of MTBC isolate was performed using a standard proportion method on algae media. For the second method is DNA extraction and whole genome sequencing. Genomic DNA was extracted at Muhimbili University of Health and Allied Science (MUHAS) using a modified protocol based on RFLP, which is restriction fragment length polymorphism. DNA samples were shipped to London School of Hygiene and Tropical Medicine, United Kingdom, for whole genome sequencing. The DNA were shipped in screw-capped cryo-vial and sealed with parafilm material. During shipment, the DNA were packed in double box and transported in ice pack with insulated material in a thermostable shipping box, where the styrofoam was at least 1.5 in thick. For the third method is bioinformatics and genomic data analysis, which are quality control and mapping of rates, variance calling and in silico resistance and lineage typing, and phylogeny reconstruction. For the fourth method is analysis of clinical data. Descriptive statistics was performed for demographic characteristics, frequency, and distribution of mutation patterns in MDR-TB and other resistant patterns in MTBC. From the results in this research article, based on baseline demographic and clinical characteristics of study participants, second, analysis of mutations associated with phenotypic drug resistance to anti-TB drugs, third, treatment outcomes and culture conversion rates among the drug-resistant TB isolate, and fourth, phylogenetic analysis of drug-resistant TB isolates. I will continue with the discussion. This cohort study performed WGS on 87 from MTBC DNA isolate, 57 and 30 patients with drug-resistant and susceptible TB respectively. Drug resistance was determined by expert MTB-RIF assay and phenotypic culture-based drug susceptibility testing, which is DST. WGS and bioinformatic data that predict phenotypic resistance to anti-TB drugs were compared with participant clinical outcomes. There were 47 female participants and the median age was 35 years. MDR-TB participants had MTBC with multiple mutant genes compared to those with mono or polyresistant TB, and the majority belong to lineage 3 Central Asian strains CAS. Also, MDR-TB was associated with delay culture conversion. WGS had high concordance with both culture-based DST and expert MTB-RIF assay in detecting drug resistance. And the last is conclusion. WGS uncovered mutation in genes that predict phenotypic resistance to anti-TB drugs, signifying its importance informs decisions making prior to anti-tuberculosis therapy. Expectedly, WGS was robust in ruling out DRTB, especially in absence of detectable mutation, which was the case in drug susceptibility and tuberculosis clinical isolate. The WGS-based DST is the best correlated with culture conversion rates and treatment outcome, indicating its potential application in designing an optimal individualized treatment regimen for favorable treatment outcomes in TB endemic setting. Thank you for watching this video.